Thanks for coming out, everyone. It's good to see you all here today. My name is Tom Landy. I'm the director of the McFarland Center for Religion, Ethics, and Culture here at the college, and I actually get to take my mask off, which I forget. The McFarland Center sponsors and supports lectures, conferences, classroom visits, special events, faculty workshops that help us explore questions, basic human questions of meaning, morality, and mutual obligation. It's been a great and busy week for us, and this is a marvelous cap-off to it. If you missed any of our great events this semester, you can catch them online on our website at holycross.edu/McFarland Center, where this event will also be posted soon. But all of you are here in person and have the great opportunity to engage a really wonderful speaker and to ask questions, so I'm glad for that. Today I'm really pleased to welcome Dr. Sandro Galea to speak about what we've learned about COVID-19 so far and what foundational forces we need to address in our society to prevent another public health crisis like the one we've been experiencing in the last 18 months. Interestingly, we reached out to Dr. Galea 2 years ago, inviting him to speak here in the spring of 2020 about social inequalities in our society that affect public health. At that time, he'd recently published a book called Well, a prescription for a healthy world that recognizes the role of things like poverty, violence, educational inequities, housing instability, food insecurity, poor air, water, and racism on health outcomes. In 2020, he and colleague Michael Stein published Pained, a collection of short essays and data further pushing the conversation about American health toward matters of class, money, and culture. In March of that year, when the pandemic shut down our campus, along with most of the country, we were forced to cancel Dr. Galea's talk. Now, 18 months later, we're grateful for the opportunity, more timely than ever, to finally bring him to Holy Cross. In his new book, The Contagion Next Time, Dr. Galea applies his ideas of what makes a healthy or unhealthy society to a real-world worst-case scenario, a global pandemic. He explains how societal conditions hindered our ability to contain and respond to COVID-19 and how we must address them to create a healthier world to withstand the next pandemic. You're welcome to a free copy of the book. They're available just outside of Ream Library. Dr. Galea is a physician, a social epidemiologist, dean, and Robert A. Knox Professor at Boston University School of Public Health. A native of Malta, he moved to Canada as a teen and earned his medical degree at the University of Toronto. After working with Doctors Without Borders in Somalia, he shifted his focus to public health and earned a graduate degrees from Harvard and Columbia. Following academic and leadership positions at Columbia, the University of Michigan, and the New York Academy of Medicine, he became the youngest public health dean in the country with his appointment to Boston University in 2015. He's published more than 900 scientific journal articles, 50 chapters, and 18 books, and his research has been featured extensively in current periodicals and newspapers. He's been listed as one of the most widely cited scholars in social science. Dr. Galea was named one of Time Magazine's epidemiology innovators and has been listed as one of the world's most influential scientific minds. He's past chair of the board of the American Schools and Programs of Public Health, past president of the Society for Epidemiologic Research and Science, and an elected member of the National Academy of Medicine. So given the many demands on Dr. Galea, we, as a public speaker and as a dean, we're really thrilled that he's with us today. So thank you and welcome.
Well, I feel like I can honestly say that it's unusual for me to be looking forward to a talk for 2 years, but it really has been 2 years since I was first reached out to, and I feel like a pandemic got in the way since you last reached out to me. So thank you very much for having me here. It's really an honor to be here with you. You've all seen the copies of my book, and in my talk I'm going to touch on much of what's in the book. Unfortunately, I realized by doing that it's sort of giving you a reason not to read the book, but I'm hoping that I will entice you to read the book and to see much more about the topics I'm talking about here. So I'm going to talk about COVID, and because COVID has both been on all our minds. But as you will see in my talk, a lot of what I'm telling you about COVID, I could have actually said in 2019 when I was initially invited. When I was initially invited, as Professor Lander mentioned, COVID was not even a glimmer in our minds, and a lot of what I would have talked about then is the same as what I'm going to talk about now, which should make us realize that there were a lot of things that we knew ahead of COVID that we should have been aware of, that we should have done before COVID, which would have saved us a lot of pain and would have mitigated much of the COVID tragedy. So with that introduction, I'll start from a place that's perhaps unexpected, because I know that as we're thinking about COVID, you're expecting me to talk about all sorts of bad stuff, which I will, but I want to start with things that went right, because I think it's important to realize what went right to the end of understanding why it went right, so that then we can look at what did not go right, so we can understand that. So what did go right during COVID? Well, one of the first things that went right during COVID is this. So this is a looking at death over time. But what I want you to look at is, this is from New York, from a cohort of people in New York. And the gray bars are number of people going into hospital. But look at the blue lines. There's dark blue line and light blue line. It doesn't matter. They're roughly the same. One is adjusted, one is unadjusted. What I want you to see is those lines are mortality. You see how mortality drops dramatically between March, where it was 25%, June, it's 5%. So the way to read that is, a new disease hits, never heard of it, people start going to hospital, a quarter of them are dying, right? That's the panic of March. But 3 months later, we had in our hospitals figured out this disease well enough that we had dropped mortality 5-fold in just 3 months. That's fine. That is extraordinary. When you think about that, right, that is actually quite amazing, that we dropped mortality 5-fold in the course of just 3 months. And that shows that our healthcare system actually knows what it's doing. That once you're in hospital, you're being looked after well. We improved clinical experience. We started using pharmacological treatments like remdesivir. We had non-pharmacological treatments like proning, which means essentially caring for people on their stomach. And all of that made a big difference. Now, the really big thing that went right in COVID, is vaccines. It's hard to remember now, but in the summer of 2020, we were having national conversations about what if we had one vaccine that was 60% effective? What will we do then? But we didn't have that. We ended up with 2 vaccines, more than 90% effective, and very safe. That is remarkable. 8 months after the first time we had COVID, we had 2 vaccines, more than 90% effective, that were remarkably safe. Normally, it takes us at least 10 years to get to a vaccine. The fastest ever vaccine we had developed before COVID was mumps, which took 3 years. Vaccines cost a lot of money to develop, but that's neither here nor there, because of course the reason that vaccines were such a triumph is because we had invested in the technology to make them for a long time. So the mRNA platform, which as everybody here has heard, was the platform for these groundbreaking vaccines. This is a paper that was published 10 years ago. And I like this paper because it has this amazing prescient sentence. mRNA presents a promising vector that may well become the basis of a game-changing vaccine technology platform, right? Let's talk about a sentence that really presaged what happened. So we've been investing in these mRNA platforms for decades, and then COVID comes and they really are transformative and life-changing. These are all things that went right. And what these 2 things have in common, the functioning of our clinical care system and our vaccine technology, is that these are areas that we have invested a lot of money in for many decades. So that's what went right. Now, what went wrong? Let's talk about what went wrong. Well, COVID has affected the whole world. We've had more than 5 million deaths. More than 200 million people have been infected. In the US, we've had more than 700,000 deaths from COVID. You know, it's hard to wrap your brain around that. It's hard to wrap your brain around like 700,000 deaths. But that's 700,000, grandmothers, grandfathers, wives, husbands, daughters, sons, lovers, right? That's like 700,000 people who died in COVID. It's hard to wrap your brain around. This is the map of the world. This is the map of the different waves around the world. And this is actually the map of vaccination, which I'm not going to talk about much, but we can talk about in the Q&A. And really just to point out that while we had this enormous success with delivering vaccines, we've had this enormous failure with actually getting vaccines into people, with a tremendous heterogeneity in vaccinating people. This shows you that in sub-Saharan Africa, we're still dealing with about 2 to 5% vaccination rate, despite the fact that now we've had the vaccines available for a year plus. This is a map of the US at one point in 2020. This is a map from the New York Times. They used red to illustrate the greater density of where there was more COVID cases. And the reason I'm showing this map is if you were an alien landed into this country, not knowing what was going on, and you looked at this map, you would know that this is nothing good, right? It really looks like the whole country's on fire. And that's how it's felt at many times during COVID, like the whole country is on fire. We've been through many waves of COVID in this country. We're right now at the tail end of the Delta wave, unclear if we're going to have another wave or not among people who are unvaccinated. We'll see. And in this time, we've had deaths not just from COVID, and this is very important, but also death from all sorts of other things that are higher than normal. This looks at excess deaths. The red line is 2020. The gray lines at the bottom, as summarized by the black line, which is the average, looks at excess deaths in the previous years. And what you see here is that we've had excess deaths substantially higher than previous years. Oh yeah, this works. That's the red line, thank you so much. And this is the black line, you see? So all of this is excess mortality in a time in diseases other than COVID. COVID became the third leading cause of death in 2020. So this is heart disease first, cancer, and then COVID. Now remember, until December 31st, 2019, we had never heard the word COVID. Just I never heard of it. So what if I were to tell you right now that in 2024, let's take year 2024, there's going to be a disease, you've never heard of this name. You'll hear about it just at the turn of the year, and it will become the third leading cause of death in 2024. How does that make you feel? Like, it makes you feel a certain urgency, right? Certain anxiety. Like, well, what should we do to prevent that? Like, that's bad, right? It's bad. It's bad that in 2024 there's going to be a disease that you've never heard of. We won't tell you about until the turn of the new year, and then it'll become the third leading cause of death. That's the impact that COVID has had. And that teaches us that we should do everything we can to mitigate the potential consequences of any such disease, which is why I think it's so important right now that we learn from COVID to do that in future. COVID has resulted in a downturn in life expectancy. This is life expectancy in the US, and this here is the COVID times. This is male and female and the overall total. And we've had the biggest downturn in life expectancy that we've had in this country since World War II. World War II, we had a downturn in life expectancy, which was driven mostly by young men who went off to war and died in war, and because there were young people who were, particularly men in that case, who were dying, young people have a big impact on life expectancy because you die young. COVID has had this impact despite the fact that most people who've died have actually been at the older end of the spectrum because more people have died. And we've seen these pictures of death after death from COVID, and I never want to forget when we're talking about numbers that we're dealing with people's lives. Now, one of the key features of the consequence of COVID has been that these deaths from COVID have not been experienced equally. You may remember at the beginning of the pandemic, there was a lot of conversation that, well, the virus doesn't discriminate. Everybody's at risk from the virus. It's true, but it also is true that the virus does discriminate. That in fact, it has not been even, the consequences of COVID. This is one of the axes of difference. This looks at the difference in death rate between Black Americans and white Americans. So the red is adjusted and the blue is unadjusted. Let's just focus on the red. This is Black Americans and white Americans. This is the mortality rate, and Black Americans died twice the rate of white Americans, about 2.2 times. So Black Americans died at twice the rate than white Americans. And remember that because I'm going to come back to that, because I'm going to use that to illustrate some other broader points. There was a higher death rate among other groups, Indigenous Americans, Latinx Americans, groups that are characterized by low wage earning, but I'll come back to the black-white difference. We're going to use that as an illustration throughout. Now, it hasn't just been direct health consequences of COVID. There have been tremendous number of health consequences of COVID in other ways as well. When I go back to the life expectancy drop, the life expectancy drop has been dramatically different between groups. The group on the right is life expectancy group drop among white women, which has been about a 0.7 year loss in life expectancy. 0.7 years drop in life expectancy is very high. By way of illustration, we have not had a 0.7 year drop in life expectancy among white women in this country since the 1918 flu pandemic. We've had drops in life expectancy in this group, but they've always been about 0.2, 0.3. So 0.7 is very high. Among Black men, the drop in life expectancy is 3 years. Now, Black men already have the lowest life expectancy by any large gender ethno-racial grouping, roughly have a life expectancy about 10 years less than white women, and black men have dropped by about 3 years. That's the impact, and that's the depth of the unequal impact that COVID has had on the health of populations. And our efforts to mitigate COVID have resulted in their own problems. So one of the ways in which we aim to mitigate COVID right at the beginning was through lockdowns, which resulted in shutdown of many occupations and resulted in unemployment. Our employment dropped precipitously, taking us to the lowest level since 1975 in unemployment. And of course, that unemployment was also not experienced equally. So this looks at unemployment and takes that same unemployment curve I showed you before and stratifies it by high wage and low wage earners. And what you see here is, right, both groups went down, but high wage earners recovered by June. In fact, high wage employment is now up 10% to what it was before COVID. Low wage employment remains 20% down. So the direct health effects of COVID, borne disproportionately by low-wage workers, people of color, with overlap between the groups that I'll get to in a second, and the indirect consequences, mediated through job loss, mediated through unemployment, is also borne disproportionately among low-wage workers with tremendous overlap with people of color as well. Another way of looking at this is looking at by income. As I said, this is highest income quarter, second income quarter. So these two groups are essentially the top 50% earning Americans. You see those jobs increase. Lowest 50% earning Americans, those jobs decrease. And these jobs are jobs in retail, jobs in the service sector, jobs in the hospitality industry. One can look at these jobs in many other ways. This looks at unemployment rate, again, by racial groups. And what you see here is this, the way to read this is before the COVID recession, during the COVID recession, after the COVID recession. Look at black Americans versus white Americans. 6 goes to 16, comes back to 9. This was 3 compared to 6, goes to 14 compared to 16, comes back to 5 compared to 9.7. We can look at other axes and other axes of disadvantage. For example, education. Top left is you have less than high school diploma. Bottom right is you have college degree or higher. And you see if with less than high school diploma, 5 goes to 21, came back down to 9. This was 2 compared to 5. Go back up to 8 compared to 21, comes back down to 3 compared to 9. And it gives you a sense of the social stratification of the consequences of COVID and the consequences of COVID. What is particularly heartbreaking about this is because you might be sitting there thinking, okay, well, there was a recession, and it was, and as a result, it was borne harder by people in low-wage earning groups. And you might be sitting there thinking, okay, well, isn't that always how it is? Well, yes and no. It doesn't have to be like this. In fact, when you compare recessions, the 1990 recession, 2001 recession, 2008, and the COVID crisis, these two lines, the green line is the highest earning quartile, and the purple line is the lowest earning quartile. What you see is in these previous recessions, these two groups did not deviate from each other very much. Look at the COVID recession. Look at the enormous deviation in job loss between the highest earning quartile and lowest earning quartile. It was the characteristics of this particular recession that resulted in groups that are already marginalized ending up bearing the brunt of substantially more disadvantage in the COVID recession because of the type of consequences it had, because of the actions that we took that ultimately ended up affecting other people. It is then no wonder that we experienced during COVID the largest wave of civil unrest the country's ever seen. In 2020, anywhere from 10 to 20 million people were engaged in some sort of civil protest. Now, this civil protest was catalyzed by the killing of unarmed black men and women, particularly George Floyd, but also others. But it wasn't just that, right? It was a recognition of the deep injustice that was embedded in this uneven experience of COVID that was felt much more clearly, perhaps, than it ever had been before. So, acknowledging that things went wrong, I think it's important to say, why did we get things wrong? Now, I could spend a lot of time, spend many, many hours talking about why things went wrong, and I could take this question from any number of different angles. But what I'm going to do, by way of illustration, is I want to talk about the black-white difference in COVID mortality. I'm going to use that as an example. And again, I'm focusing on the black-white difference. One could also talk about indigenous populations, low-wage earning groups. We could talk about Latinx populations. But I'm focusing on the black-white difference as an illustration. Then we can talk about other groups if you want. Remember, I said black Americans had about a 2.2 time mortality rate greater than white Americans. So I'm going to say, why was that? Because by looking at why that was, It helps illuminate what happened in a time of COVID. So why was that? Well, there are two reasons why that was. One is there was a differential risk of getting COVID. Now, what do I mean by that? Well, how does one get COVID? COVID is a respiratory infection. It's transmitted person to person. The way one gets COVID is by being around other people. The way one does not get COVID is by not being around other people. Well, when COVID was recognized and when COVID was declared a national emergency, who was able to protect themselves from COVID? Well, these two lines are the gray line are the wealthiest 20% of the population. The red line are the poorest 20% of the population. This is the COVID national emergency declared. COVID national emergency declared, the wealthiest 20% stay home, the less wealthy 20% much less so. Looked at another way, your ability, for example, to work remotely is directly proportional to how much income you make. Highest earning quartile of Americans is from Bureau of Labor Statistics, much more likely to be able to work remotely than the bottom earning 25% of Americans. In fact, one of the challenges that I think we have, and by we, I mean those of us in the academic environment like this, I know you're all students, but it's also sort of you're part of this academic environment, is that our contacts are consistently and robustly here. And one of the things that I find is a challenge in my environment is that most people around me, everybody they know, is actually working from home part of the time. In fact, many people are not working from home. Let me ask you a question. What percent of Americans last month worked any part of their time, among working Americans, worked any part of their time from home last month? Anybody? You can speak up. Don't be afraid. 40. Somebody else, give me another answer. 60. One more? One more answer. 75. 9%. The percent of Americans last month who worked any time from home is 9%. 40, 60, 75 are reasonable answers. And in fact, in the world I live in, around me, those are the correct answers because everybody I know worked a little bit from home. In the whole country, 9% of Americans worked at all from home in the past month. So it just illustrates how much the country is, the people who are in places that are close to seats of power and where decisions are made is different than where the rest of the country is. Most of the country did not have the opportunity to work from home, and most of the country, that exposed it to greater risk of COVID. And of course, that has a lot of overlap with ethno-racial grouping. Black Americans are much more likely to be in essential industries than people in other groups, and that is what determined the initial higher risk of getting COVID. Now, it's not just about getting COVID, it's about getting risk of severe COVID, of having COVID that is severe. Now, what determines the risk of severe COVID? We've known this from the beginning of the COVID pandemic. The risk of getting COVID being severe COVID is determined by underlying conditions. This is a slide from the China CDC in February of 2020, which shows that death from COVID much higher if you have stroke, diabetes, respiratory disease than if you have none of those. In fact, one of the things that's been poorly communicated in time of COVID is that if you have no underlying morbidity, in fact, your chances of dying from COVID are actually quite low. So severe COVID is driven by you having underlying conditions. Now, who has more underlying conditions? Well, those with underlying conditions are those with lower income and, in this country, overlapping a lot with people of color. So this looks at income decile, you see it? So more income here. The yellow bar is having illness that predisposes you to severe COVID, things like heart disease, lung disease, diabetes, hypertension. The more money you make, the lower the yellow line. Everybody see that? So the more money you make, the less likely you are to have underlying illness that makes you vulnerable to severe COVID. The green bar is underlying mental health condition that makes you vulnerable then to mental health consequences of COVID. And again, the higher the income, the lower the green bar. So essentially, the more income you make, you're in a higher income bracket, the less likely you are to be vulnerable to severe COVID if you get COVID. So you have to add reason A, which is persons low income, overlapping quite a bit with people of color, more likely to get COVID. Reason B, when you get COVID, more likely for it to be severe. You add reason A to reason B, and you end up with the observation at a crude level of twofold greater risk among black Americans compared to white Americans of dying from COVID. Because when you look at the burden of morbidity among black Americans versus white Americans, this looks at high blood pressure, diabetes. The blue line, the blue bar is black Americans, the red bar is white Americans. Black Americans have higher blood pressure than diabetes at young ages, middle ages, older ages. And why is that? Why is there this underlying pattern of greater morbidity? This underlying pattern is due to centuries of marginalization and forces like structural racism that have structured the world in such a way that particular groups, in this case we're talking about black Americans, have not accumulated the assets that can generate health. This, of course, ties into the history of slavery in this country. This is a map of slavery in 1860, which then was followed by Jim Crow laws and followed by things like redlining. This is a map of redlining. Redlining emerged from an effort by Congress to encourage Americans to own homes. A worthy effort in and of itself, but of course, the Homeowners Loan Corporation that was entrusted with encouraging banks to lend people money for mortgages would take maps of cities, this is Detroit, and would color in the maps. Green, places where banks are encouraged to lend money, yellow, where banks are like maybe, and red, where banks are discouraged from lending mortgages. And of course, the red areas are areas which were predominantly African American neighborhoods. That is where the term redlining comes from. It's from redlining on maps. That resulted in African Americans being less likely to own homes, less likely to accumulate wealth, more likely to be in low-income jobs, more likely than to be exposed to COVID when COVID hit. Tracing, really, a historical path of disadvantage, which then manifests in COVID times. So hopefully by seeing that story, everybody understands how COVID did not result in anything new. These patterns of disadvantage, marginalization, and greater burden of disease in one group versus another was already there. It was there not just for years, not just for decades, but for centuries. But COVID made them apparent by capitalizing on these underlying fissures and groups which already were health have-nots. So now, accepting, understanding what we got wrong, it becomes important to say, why did we get it wrong? Because if what I'm telling you, and I said this in my preface, that it was not in and of itself new, then it seems reasonable to ask, well, why? Why did we get it wrong? So we got it wrong for two reasons. Because we have long in this country underinvested in what makes us healthy and underinvested in what can keep us healthy when something like this happens. So let me start with underinvesting in what makes us healthy. And I'll start by telling a story. So this man is Blind Willie Johnson, who is a blues singer. If any of you are fans of the blues, you'll know his name. Blind Willie Johnson, the story goes, was born sighted. He was born in Texas at the turn of the 20th century, in early 1900s. He lost his eyesight when he was age 7 in a domestic violence incident. Blind Willie Johnson grew up poor, blind, black in Texas in the early 1900s. He got married. Him and his wife were living in a small house. The house at one point burnt down in an accident. They weren't hurt in the fire, but they had no money, so they were homeless afterwards. So essentially they went back and they were living in the burnt out shell of the house. When he was in his early 40s, so it's now 1940s in Texas, he got malaria. Blind Willie Johnson got malaria. Now malaria in Texas in the 1940s was very common. It was quite common in the southern states, all over southern states. Nothing particularly unusual about him getting malaria. His wife took him to hospital, and he was turned away from hospital. Unclear if he was turned away because he was poor, because he was black, or because he was blind. And then he died. So the question is, what killed Blind Willie Johnson? Anybody, what killed him? Lack of health care? What else? Anybody else? Other answers? Lack of housing? What else? You can feel free to yell it out. You're all wearing masks, so I wouldn't even know who said it. Say it again, sorry? Yeah, his initially his childhood poverty conditions, right? All of these things are true, but what really killed him was malaria, right? Malaria is what killed him. Had he received treatment for malaria, he would have lived that day. But you all noticed correctly that it wasn't just malaria that killed him. It was the conditions he grew up in, lack of access to care. It was racism. It was homelessness. All these forces contributed to his death. Now, why am I telling you this story? I'm telling you the story because I think it is a metaphor for how we think about health and how we need to think about health. Because our dominant paradigm of thinking about health is all about malaria. And even in COVID, it is the equivalent of all about malaria, which means it's about the coronavirus and it's about the vaccines. But when I tell you that story, it's hard to avoid the obviousness of how the other forces influenced his life and influenced his death. And the answer then is that in order for us to generate health, we need to pay attention not just to malaria, but to all the other forces that shaped his life. Now, I've told you this by way of story, but I could tell you this in many other ways. This is a figure from the Institute for Clinical Systems Improvement showing health and healthcare accounts for 10 to 20% of health. Tobacco use, diet, quality of our community, safety, income, family support, job site, education is the other 80 to 90% of our health. This is broadly understood. It's hard to sort of find argument with it, but despite that, that's not what we spend our money on. The figure on the left is the same as the color figure I showed you before. This is just taken from the book you have in your hands, showing medicine 10 to 20%. 90% of our spending is on medicine. Only about 3 to 5% is actually spent health on other forces. And we spend a lot on our health. We actually spend a lot on our health. This looks at our spending. Us, this is us. These other colorful lines are other more rational countries. They spend about 30, 40% less than we do, despite the fact that we actually have much worse health than they do. Looked at another way, this is our spending on medicine and healthcare programs. The light blue, you see how it's going up, ignoring Social Security? See how all other spending is actually going down over time. And we have paid the price for that. Because in this country, our life expectancy is about 5 years less than it is in all other high-income countries. That's all other high-income countries. That's us, about 5 years less. We have essentially agreed as a country to die 5 years younger than the people in other high-income countries. Now, those of you who are American may say, well, I didn't actually agree to that, but you effectively did, because you are part of we are part of this collective decision-making that results in how we treat health, which means that we can expect to live 5 years less than people in other high-income countries. And if we do not like that, we should actually change what results in exactly this. So it's a funny turn of affairs, right? We spend more on health than any other country, and we get less out of it compared to high-income countries. Let me ask you this question. Can you think of any other sector where we spend more and get less? There really is no other sector. There's not a sector where we spend more and get less. Suppose I were to tell you that your smartphone that you have in your pocket or in your hand right now costs more than what the smartphone you can buy in any number of other countries, but it's slower, holds less data, the screen is less sharp. I bet Apple wouldn't be doing so well then, right? We're willing to pay more when we feel we're getting a product that's at least comparable. With health, we pay more and we get less. And I would ask you, I would challenge us to think, why is that? Why do we even accept that? And of course, this getting less out of health is also not evenly distributed. When I look back at black versus white mortality rate, for example, again, blue is black Americans, red is white Americans, higher mortality among black Americans, young ages, middle ages, older ages. One way to look at this is a slide that sort of captures all of this together. On the x-axis, we have spending. On the y-axis, you have life expectancy. You see all these other countries, you spend more and you get more life expectancy. But look at us, you spend more and we get less life expectancy. We're like falling off the curve. And that shows how unique this country is, and largely is because of our misinvestment. So reason A, why we did so poorly, is underinvestment in what makes us healthy. Reason B is underinvestment in what may have helped. Now, what may have helped fundamentally is public health that is funded in such a way to be able to mount rapid testing, rapid screening, rapid isolation of people in a time of COVID. And that is not what we've done. Our state and local public health workforce has been shrinking. I often tell our students that this is the best time ever to be in public health and to be graduating in public health, because this is bound to change, because we have realized as a country how foolish this is, and there's going to be a lot more public health jobs, a lot more spending in public health in the coming years. Most of our states spend less than $100 per person in public health. The darker the color here is the less money spent. And even though there have been efforts like the Federal Prevention Fund, we tend to underspend those efforts. So this is what is allocated, and this is what is actually spent. And going back to some of the civil unrest earlier, perhaps this slide captures it best of all. The red are counties where we spend more on policing than we do on health. Most counties in the US, we spend more on policing than we do on health, which now, remember back to civil unrest I talked about before, that was catalyzed by police shooting of unarmed black men and women, and also by the underlying poor health and inequities in health. And of course, if in a map of the country, we're spending more on policing than we are on health, that explains, in many ways, both of those phenomena that drove the civil unrest. So, I suppose I'm here to say that we should seize the COVID-19 moment as an opportunity, that we have learned a lot in time of COVID, and COVID was a tragedy, an unmitigated tragedy, and nothing will redeem it. But it becomes even more of a tragedy if we do not learn from COVID. So how do we learn from COVID? Well, what do we learn from COVID? I think we learned that we need, here I've called it a Health New Deal. Sadly, I wrote this in March 1st, 2019, exactly a year before COVID, as you see right there. Where essentially I told you, I was saying the same things I was telling you here. COVID hit and elevates those things in visibility, but fundamentally we've known this for a long time. For those of you interested in a career that does this kind of thing, confidence in medical scientists is going up, which is good news, which means that there is an opportunity here to inflect the global conversation on this. And when you look at what we should be doing this. We should be working to generate knowledge that can inform action, and working to motivate the values that allow action. We should be over here, creating knowledge and creating values. That's fundamentally what it is that we should be doing. And we should be doing that while doing ever better science. So as I look to conclude, I'm going to talk for another 5 minutes or so, and then I'm going to get questions. So start thinking about your questions. I want to talk about how we can do better science to better serve this agenda. I know that many of you here are interested in careers in health sciences, careers in medicine. So this is my challenge to your generation, to think about doing ever better science than we've done during COVID to serve the ends of creating a healthier world. So what does ever better science look like? I think we fell short of our promise in science in many ways. And here I'm going to talk about them in this way. I'll start with false certitude. I think COVID hit, and we in science offered many, many things that actually turned out to be wrong with tremendous confidence that belied our uncertainty. For example, there was a tremendous amount of modeling around the virus which we proposed with great certitude, guiding policy in a way that was ineffective, resulting in predictable sort of public backlash about the failures of influential COVID-19 models and whether or not science is to blame. When we think about modeling exercises, this is from a paper which I really like this phrase, when a lot is at stake, it's wise to be humble when faced with fundamental limitations. Models are usable if they take into account uncertainty. If that's not the case, the results are on a par with assumptions or guesses. A lot of the modeling that you saw and you read daily in the newspapers was fundamentally based on scientific guesses, even though it was not presented as such. And that has done science standing a disservice because we have been uncomfortable admitting what we do not know. When in fact there's been a lot we do not know. And in fact, the public actually is quite comfortable with us communicating uncertainty, even though we did not do it. It's from a paper about the effects of communicating uncertainty in public, saying communicating uncertainty only exerts a minor effect on trust. Knowing this should allow academics and science communicators to be more transparent about the limits of human knowledge, but we have not done that. We have contradicted ourselves without acknowledging the fact that we're contradicting ourselves, most dramatically about masks. This was initially sort of science was saying we don't need a mask to avoid coronavirus. Then, of course, we realized that that's not the case, and that's fine. But a lot of our approach was essentially trying to delete from public record what we thought we knew, rather than acknowledging the uncertainty that led us there. And perhaps most egregious of all our sins was in science, we were intolerant of disagreement. There have been things, for example, like the Great Barrington Declaration, signed by a lot of prominent scientists, which resulted in this enormous opprobrium from the scientific establishment, including, for example, this from Union of Concerned Scientists saying herding people to slaughter, the dangerous fringe theory behind the Great Barrington Declaration. And that is exactly not what it was. The Great Barrington Declaration was actually fairly reasonable set of proposals, some of which I disagree with, but some of which I agree with, saying things like this.
Adopting measures to protect the vulnerable should be the central aim of public health exposure to COVID-19. Nothing wrong with that at all. Retired people living at home should have groceries, other essentials delivered to their home. Nothing wrong with that at all, which is why it sort of shows that us clamping down on disagreement, which the Great Barrier Declaration did on particular angles, has been not productive to science and has diminished, I think, to my mind, the standing of science. Of course, a lot of this came out in the school reopening. I'll talk about schools in a second. This is the Philadelphia school superintendent wanted to reopen school, facing an outcry saying we should not have to teach our students to death, which is, of course, far from what was really the truth. So why did science fall short of our promise? I think science fell short of our promise for 3 reasons. We're dealing with very complex systems. Let me continue on schools for a second. Schools have been one of the flashpoints that science has waded in, I think waded in not very effectively. Schools have roughly were closed for about a year with a lot of kids of all ages learning in hybrid. And we know that that has resulted in kids learning much less. The pink is 2019 math scores, the green is 2020 math scores, and you see how they're all shifted to the left, which means kids of all ages have been learning less. But it's not all kids again. It's differential by kids' socioeconomic position. The light blue are schools with more than 50% white students. The dark blue are schools with more than 50% students of color. And you see how the light blue is always to the right of the dark blue? That means at all grades, schools with more white kids ended up doing better with the math scores than schools with more kids of color. Not just that, schools in more affluent areas reopen faster. And all of this at a time when the risk of COVID for children, which is here for children, was substantially less, for example, than the risk of children being injured in driving to school. So in a very complex system, we made decisions that privileged particular positions that were divorced from the realities of how we were bringing about disadvantage. We were deepening disadvantage and deepening divides between health haves and health have-nots, because we know that if there's one thing we should invest in to create a healthier world, it's in education. This looks at Latino, black, white, just focus on white, they all behave the same way. You see how the step function here, this is mortality. The more school you have, the lower the mortality. So if there's one thing that we could do to improve people's health over time, is to make sure that everybody's in school. And by us closing schools and creating further gaps between haves and have-nots, health haves and health have-nots, we have been widening these mortality gaps, and which is then no wonder that there have been protests like this one about stop destroying their kids' lives. I'm going to talk about biases in science for a second as I wind down. And we've had a lot of biases in science that have come to bear on the moment. And there's been biases actually all over the country. I'll start with the biases in decision-making at the federal level. This is the 116th Congress that was sworn in. And Congress is often criticized for being non-representative of the population, which it is on multiple axes. If I were to ask you what Congress is non-representative of, you'd probably say it's non-representative on gender, non-representative on race, which is true on gender, not so much on race. Congress is actually not pretty good on race. But the area on which Congress is most unrepresentative of the population is on Congress's likelihood to represent people without a 4-year college degree. This is the country. 65% of the country do not have a 4-year college degree. You, by being in this college, by heading towards graduating from this college, by definition are putting yourself in this blue category. Fewer than 5% of people in Congress do not have a 4-year college degree. Now, I'm not arguing whether that's right or not. One could argue that people in Congress should be better educated than people in the whole country. All I'm simply saying is that Congress does in no way represents the majority of the country. Again, remember, only 9% of the country did any remote work in the past month. That's not the position Congress is in. By the way, Congress remains, the majority of congressional staff remain working from home to this day. That's how you have biases embedded in systems and decisions that are made that do not reflect what we're bringing upon populations. The academic world has its own biases. The academic world is a left-leaning world. This is far left, left, middle, right, far right, professor's associate assistant. So essentially, 90% of academics are to the middle to left of the political spectrum. That's not where the country is. The country is 50-50, which just gives you a sense of the biases that we bring to it. And this is actually what, to my mind, embeds these biases most. This is from an analysis that looked at above the line means doing better, below the line means you're doing worse. Multiple dimensions: mental health, personal finances, job security, take-home pay, physical health, personal life, work-life balance. And multiple groups. You see only one group stands out. This group did better on all of those. This group is the group with a postgraduate degree, which is essentially everybody in the academic world. So everybody in the academic world, everybody in science, everybody in medicine, actually did better on mental health, personal finances, job security, home pay, physical health, personal life, work-life balance during COVID. When that's what your social group is experiencing, that pushes you to do a different kind of science, ask a different kind of questions, and promote a different set of policies than you might otherwise. And coming back to an axis I talked about quite a bit, which is the axis of color, this looks at epidemiologists, which of course have been very prominent in time of COVID, and shows that epidemiologists, more than 75%, are either white or Asian, with substantial underrepresentation of Black Americans or Latinx Americans. And finally, groupthink. That we have had a fair bit of groupthink in a time like this, and the groupthink has led us to things like zero COVID. I'm sure you've all heard of zero COVID, which is this notion that we could eliminate COVID. The problem with that is that's really a spherical cow fallacy. Spherical cow is an old saw in science, which is where scientists says, assume a spherical cow of uniform density. The problem with that is there's no such thing as a spherical cow of uniform density, of course, so starting with that assumption is not very useful. Zero COVID assumes that we can eliminate COVID, and if you assume you can eliminate COVID altogether, you go down a path that is dramatically different than if you assume that we need to learn to live with COVID, and that we have allowed that to happen. We've allowed whole countries to adopt that, which eventually, by the way, all countries, with the exception of one, have now dropped zero COVID completely. The only country that's kept zero COVID is China, and China continues on the notion that it can eliminate COVID. It won't. It will fail eventually. But the only reason it can continue it is because of a very, very, very strict authoritarian approach to COVID, which would be intolerable in all other countries in the world. And this groupthink, by the way, is particularly pernicious in our environments, in blue versus red political environments in this country. This looks at living in political bubbles. And what you see is 38% of Democrats in this country live in a bubble, which means all your neighbors are essentially Democrats. Well, 19% of Republicans live in a bubble. We talk to each other, and that reinforces our biases. And I showed this slide to my school community. This came out in 2019 from a study that was done. The most intolerant county in America is Suffolk County, which is actually exactly where my school is located. So for all of us here, who I think is a safe assumption that this room is a predominantly left-leaning room, just because that's what rooms like this tend to be like, that we actually tend to be much less tolerant than people who are not. And I think it's important for us to keep that in mind as we think about our biases. So I'll conclude with an argument for reclaiming what I call here liberal public health, which means a public health that's based on principles of the Enlightenment, respecting personal autonomy, reason, and logic. And I think to do that, there are three paths forward, and I end with these because I knew I was talking to an audience of mostly students, and it's a bit of a challenge to you all as you embark on your life journey, as many of you embark on a journey in health sciences, and as you think about how you want to approach a world that will face the next pandemic. You will face the next pandemic when you're at the peak of your professional careers. There's no question about it, because in the next 40 years, there will be another pandemic. I'm hoping I'll be long retired or dead by then, but you will have to deal with it. One is humility. As opposed to arrogance, being clear about what we do not know. It's been hard to be humble these days because, newspapers keep running articles like this, like what epidemiologists are doing for Thanksgiving, what epidemiologists are doing for Christmas. And, that makes you feel kind of special. But that's not very helpful. That leads to arrogance, our tendency to overestimate our ability to predict when we're overconfident in our knowledge, and that's something that we should be avoided at all times. Two is radical compassion. The notion that actually we need to be compassionate people who are unlike us. We recognize our biases, and we recognize that decisions that are made informed by our science are affecting other people adversely. And what do I mean by that? Ability to work remotely. Everybody around you in the top 25% of income is able to work remotely. Nobody in the bottom 25% of income is able to work remotely, which means that we need to recognize that particular policies that say only essential workers need to go into work means that actually now essential workers are the ones who are at high risk. And you're dictating that from the comforts of your home, being safe from COVID. Radical compassion says we should need to keep that in mind. We need to recognize that when we make decisions that result in particular sectors of the industry being locked down, that means we're consigning groups, low-wage groups, to losing jobs when we're not. And we need to recognize that decisions that are made about COVID result, for example, in this extraordinary, heartbreaking rise in other diseases like death from opioid overdoses, which went up to 93,000 in 2020. 100,000 people died from opioid overdoses between April of 2020 to 2021, which is a 30% increase over the previous year, driven largely by poor mental health and by social isolation. And those are the consequences that we need to keep in mind. And finally, to talk about reform through reason. And I've written about this, and I've written about this. This is a piece where I talked about a radical vision for creating a healthier world, but being willing to roll up one's sleeves and do the hard work, the incremental hard work to achieve the aspirations of public health. And that's fundamentally what the book that's in your hand is about. Thank you for having me. It's a real privilege to be here, and I want to stop here to give us 10 minutes for questions. I'm happy to take any and all questions. Thank you. Race is not a valid biological construct. Our genetic differences that result in our different phenotypes that we actually call race are essentially insignificant biologically. Race is ultimately a social construct. President Obama himself, to use the example you said, when he was asked about the fact he has a white mother and a black father, why he considers himself black, he says, not about what I consider myself, it's how other people see me. And I think that's exactly what determines the construct of race. Fundamentally, race is a social construct, and it is social structures that result in particular groups being marginalized, whether it's determined by income or whether it's determined by race. We should be in a world where race as a phenotype is delinked from health. There should be no reason why, if you're classified as white, black, Latino, or anything like that, has anything to do with health. That should be delinked from health. The fact that health can be indexed on race suggests that we as a society are structured in such a way that people of particular racial groups are marginalized and disadvantaged. On the vitamin D hypothesis, scientists, broadly speaking, do not think that that's actually contributory to the greater differences in high blood pressure in different racial groups, that fundamentally that is because of economic and social patterning of resources available. I think there are tremendous differences between countries. In different countries, do different things better. And I think the reason I don't want to point to one country, because I don't think it's a fair comparison to say, well, the US should have been Denmark, because there are so many differences in characteristics between, let's say, the US and Denmark, that I think it's sort of an unfair comparison, that we have a much more heterogeneous country, a much larger country, much harder to make policies. But I think the answer is to look at what particular countries did and to learn from them on particular aspects, rather than thinking about one country.
Yeah, do you think that things like the false certitude and then the contradiction without acknowledgement kind of contributed a lot to that vaccine hesitancy that we're seeing right now?
I would love to say no, but I think the answer is yes. I think the vaccine hesitancy, which we've heard so much about, a lot of it is predicated on lack of trust in establishment, medical systems, etc. So that lack of trust, where does it come from? I'm often asked, how do we build trust so that people can now get the vaccine? My answer is, right now, we don't. Because once you have to say to people, trust me, you've lost trust, right? You should never have to say, trust me. And when you have groups of people who have seen health get worse in their whatever geographic, socioeconomic bracket for decades, why should they then all of a sudden turn around to trust the health system, particularly when the system says, trust me, this is a great thing. One of the most compelling data points I've seen recently actually was published by a faculty member in our school. He did a very simple correlation. Y-axis, he put percent county vote for Donald Trump. X-axis, health in the county going backwards, meaning getting worse in the 10 years before the Trump-Clinton election. It's a very clear straight line correlation. Counties where the health was getting worse, much more likely to vote for Donald Trump. Now, if you stop and think about it for a second, that's pretty rational. If you've actually been seeing health around you get worse, right? Year after year after year, and you have two candidates, one who clearly comes from the establishment, right, and is saying, hey, things are doing very well among President Obama. I'm going to continue that and do even better. And you have the other candidate who says, everything's going to hell in a handbasket. I'm going to rip it all up. You may not like that person. You may think that they're sort of full of it. But it's not irrational for you to then say, I'll take a chance on that person, because while I keep hearing from one side everything's getting better, everything around me is getting worse. So I do think this feeds into that, right? Why should you trust a system where everything you see with your eyes and with your experience is that actually the system has not helped you or your friends? So I do think that that there is a real price to pay for the arrogance and the epistemic arrogance that comes with saying, trust me, when we do things wrong time and time again. And I think that's what should suggest humility in how we do our science. So thank you, that's a really cool insight.
Thank you. I have another question. Do you think that the healthcare being linked to politics helped or hindered the pandemic?
Yeah. So I think health is always political, and I think that's okay. Now, I'm going to elaborate on that in a second. The question is, what do I mean by political? Politics is our collective act of prioritizing. That's what politics does. Politics is about how we collectively prioritize, and we have systems to do that, right? Some are elected systems, some are not, but politics is our act of prioritizing. Health, if you buy my logic, health is a product of the world around us, which means it comes from our priorities. So there's nothing wrong with health being political. I think there's everything wrong with health being partisan, which I think is quite different. And one of the tragedies of this COVID moment has been that health was partisanized, that the COVID pandemic hit at this particular point in time when we had a president in this country who was in his last year. He saw everything through the lens of re-election, and very quickly, decisions about health acquired a color, blue or red. And we saw it play out time and time and time again. And I think, you know how I mentioned, for example, the listening to other voices and the homogenization of thought and science? I think a lot of that was actually in response to the positions taken by partisan action, where it became impossible in science to say, well, let's debate whether or not one needs to wear masks. You're all sitting here, you're all wearing masks, you're all vaccinated, right? What's the science about you need to wear a mask when you're in a 100% vaccinated environment? Actually, next to nil. You're actually all wearing masks because it's inertia and because we actually feel better that way, but there's no science behind it at all, right? But can I say that publicly? Not really, because it's sort of like, if I say that, I know some of you are thinking, oh my goodness, he might be Republican, because we've become so conditioned that way. We might be so conditioned that way, right? So, and it shouldn't be. Like, we actually should be able to have that conversation. I'm not suggesting you shouldn't be wearing masks. You should wear masks for a bit longer, it's fine. Eventually you'll get over it, right? But hopefully you understand the point I'm making, that these decisions, these should be conversations that we can have, but we stopped being able to have them because everything became so partisan shaded. Thank you.
Can I ask a question? I'm struck you talked
It's
about...
your show.
Okay. You talked about the assets that provide for health, and I've usually thought of it in the opposite terms, in terms of a deficit model. So people who have X disease or precondition.
Yes.
So what am I missing? Can you talk more about the assets, and what am I missing by having framed it in a deficit model that I should be paying attention to by the assets?
Thank you. Yeah, I prefer an asset model to a deficit model. I mean, at some level, it's about semantics and framing and presentation, but I think an asset model makes it clear that we have an opportunity to provide those assets to populations, and that by providing those assets, we can make sure that we level the health playing field. A deficit model, to my mind, almost suggests that we have to help people because we are charitable. An asset model makes it clear that the accumulation of assets has been disproportionate, has been maldistributed based on structural forces. So that's actually why I prefer an asset model, because asset model makes it clear that it's about we've given to some and not to others, while a deficit model suggests that some are in a deeper hole. So that's why I prefer the asset model.
Thank you for the presentation. I think you did a good job highlighting the issues that are surrounded by COVID-19, as well as just highlighting the social determinants of health inequities, and how it's not because people choose not to follow health protocols just because, or it's mostly because of access to healthcare, income, education. All those are huge contributors to people's health, and it's like you said, it affects people of color and low-income communities. And so as we reflect on what you discussed, and like you mentioned, how we are, the next people addressing these issues in the future, because this is not the first or last pandemic we will have, how can we go forward in whatever we choose to do to address these issues? Because it's not like, someone becomes a physician and they will help that one person, but on a greater scope of things, how can we move forward to change these issues in the social structures that we have currently in our systems?
Yeah. Thank you. I think we go forward by changing the health conversation. And what do I mean by that? We've done surveys that ask people, what do you think matters most for your health? And a plurality of Americans say, my doctor matters most for my health. Until a plurality of Americans say, what matters most for my health is the fact that I have a wage I can live on and I have a safe house in which I can live in, then we're not going to see a change in this conversation. I think physicians, you mentioned physicians, but I can talk about other health professionals, are seen as the trusted source on health. And those of you who are going to occupy roles like that will be able to play a key role in conversation setting. The good news is the conversation is shifting. I mean, we are here today in, you mentioned casually the social determinants of health. You may reflect, I never used that term in my talk, which means you mentioned it because it's comfortable for you. You're aware of it, right? It's part of your thinking. You didn't even think twice about mentioning it. 10 years ago, that wouldn't have been the case. 10 years ago, if I were to speak to a room like this, it wouldn't have been the case that somebody would have casually mentioned social determinants of health. And that reflects our shifting in our conversation. So I think the conversation is shifting. I think it's shifting in the right direction. And I think everybody here, as you emerge as leaders in the space, you will see the conversation shift with you. So I suppose, the reason why I come to give a talk like this is because I'm hoping that you'll retain some of this and you'll weave it into the stories that you tell as you're shaping health in the future. Thank you very much for having me. It's really a privilege to be here.
Thank you so much.